All right, I will be summarizing the sessions from this morning that finished 30 minutes ago, starting with Leo Beletsky talking about the use of the law as a tool to address the consequences of infectious diseases and addiction. He started off by sharing with us how drug laws can shape access to syringes, condoms, etc., and shape user behavior as well. Laws can be used to reduce risk, and several examples he gave were the decriminalization of syringe and drug possession, the availability of syringe exchange programs, opiate agonist therapy, which I'll refer to as OAT, access to health care and wraparound services, for example, Ryan White Health services provided to HIV-infected persons that have reduced HIV transmission. Law can be a driver of an infection drug use initiation as well, and the example we talked about was the availability and access to opiates, which may be prescribed through legal pathways, but then translate to illegal injection drug use for many opiate users. We also talked about the translation of ID prevention into policy. Several things that came up were syringe exchange programs, OAT, and law enforcement initiatives. He mentioned that the law can be necessary, but it's rarely sufficient. And some examples he gave were states who still lack laws or may have insufficient laws. Laws may sunset or be repealed. A few examples, for example, Kentucky with its syringe exchange program, legality, but still insufficient coverage. And he mentioned that too many counties where syringe possession is a crime without any exception being made for public health issues, for example, HIV or hepatitis C outbreaks. We discussed opiate agonist treatment following a non-fatal overdose, and the uptake with that is still low. He shared some data of 5% uptake of OAT in individuals who had previously had a non-fatal overdose. Another example from the discussion that came out was regarding Medicaid and Medicare coverage in correctional facilities and how this is a barrier to MAT for individuals after leaving a correctional facility. He also mentioned that in Indiana and West Virginia, syringe exchange programs are closing. We also heard a bit about training of police and policies that can be used through law enforcement to improve outcomes. For example, he shared data regarding assessing perceptions of syringe exchange programs amongst police members and their knowledge of OAT. He demonstrated a significant impact in police awareness and attitudes towards syringe exchange and opiate agonist therapy after some education of police force members. We also discussed stigma around opiates and how that affects OAT. An example that was shared was how women on OAT may be investigated by Child Protection Services in some regions of the U.S., which is obviously a barrier to treatment for those women if they fear that their children may be taken from them if they are to go on to OAT. And finally, he discussed the need for us in the room and listening remotely to assist in making policies to ensure evidence-based practices. Then we heard from Katie Goodwin from the Anne Arundel County Police Department. She shared multiple initiatives in Anne Arundel County, which is in Maryland and is the county seat being Annapolis for those who aren't familiar. She started off by discussing Good Samaritan laws, which are in place to protect those that report potentially fatal overdoses in medical emergencies, such that a person who is in possession of drugs or using drugs will still report the medical emergency of their friend or partner without fear of legal repercussions. She also discussed collaborations between other agencies targeting dealers across county lines. Unfortunately, her county has seen 150 fatalities related to overdose last year, and current estimates show that 2018 will be even worse. The fatal overdose unit within her group has been charged with finding dealers and increasing charges to manslaughter. So this is a policy aimed at reducing drug dealers out on the street. Rather than just charging them with distribution charges, they've increased that charge now to manslaughter. She also shared that her officers are carrying at least 2 Narcan doses at any time. She said that in many cases, her police officers are having to administer multiple doses of Narcan, up to 7, to reduce potentially fatal overdoses in individuals. She shared that toxicology reports are showing an increase in fentanyl as the causative agent in a majority of cases, and she believes that's why they're needing more and more stronger doses of Narcan to reverse these potential fatal overdoses. She also shared some resources that she's handing out, linking individuals to treatment for opioid addiction. Anyone who is apprehended in her county is given information on addiction, resources in the community, contact numbers without being asked or queried as to their opiate use. They're just provided with a list of resources. She also shared an interesting Not My Child initiative, which is available in Anne Arundel County, but could be implemented elsewhere. It includes a panel of those who are using opiates, those in recovery, family members as well, to put a personal face to the epidemic, and has been very successful. It's also available for youth and elementary school as well. She also encouraged us to look into a documentary called Chasing the Dragon, which can be geared to kids 5th grade and up to prevent opiate use disorder in this younger demographic. She also shared focusing on women and specifically working with women in recovery to discuss safe environments for their children and additional challenges. She also mentioned intimate partner violence as being very high in this cohort and discussing with them ways to improve their safety and outcomes. She shared an idea for a safe prescription repository for patients to dispose of unused opiates, getting them out of the medicine cabinets where they may be vulnerable to misuse by family members or children. In the discussion, there was much discussion about the harms of incarceration for people who inject drugs. It was mentioned that there's no evidence base to support incarceration of people who inject drugs or their partners or friends of overdose victims. There was much enthusiasm for OAT during incarceration and following release in the community. There were concerns about this concept of fatal reentry, where individuals may detox during incarceration and then be released to the community only to succumb to a fatal overdose. And it was shared that OAT would be an option to prevent that. In the discussion, there were additional themes on stigma specifically related to the prior crack cocaine epidemic, which largely affected African American communities and involved criminalization, versus the opiate epidemic, which affects many white individuals. And we are now being much more compassionate, including having Good Samaritan laws that may benefit the opiate addicted individuals. Finally, Katie shared that she feels that building trust is very important in law enforcement getting involved in the community, working with the youth so that they feel a sense of support from law enforcement. Moving on to the discussion with Dr. Powderly, the immediate past president of IDSA, we heard about relevant activities, including partnering with AASLD for Hep C guidance, chronic pain management guidelines, advocating for federal funding for ID and HIV prevention and treatment. We heard about a query of IDSA members regarding issues related to the opioid epidemic who unanimously felt that infectious endocarditis, acute Hep C, osteo abscesses, and HIV were priorities. They also requested additional resources and needs related to syringe exchange programs, safer injection, education, access to MAT in primary care and specialty care, and more supportive inpatient facilities to manage infections and addiction. In terms of moving forward, there has been a working group on ID and opiate use disorder that is focusing on the need for more epidemiologic data and surveillance, especially related to Hep C around the country and the role of opioids in this epidemic. He shared the potential for us to only generate bad data without resources and funding needed for this surveillance and the upkeep of such a database. He discussed leveraging SAMHSA and HRSA for addiction training for clinicians, including ID specialists, which is a recurring theme, on the front lines of the opiate epidemic. And there was also discussion about telehealth training. One goal is to target underserved areas through loan forgiveness, to get more addiction and ID specialists to practice medicine where they're needed most, and to fully leverage the Y and White HIV/AIDS program to improve access to prevention and treatment for people with HIV with opiate use disorder. Finally, we heard about removing unnecessary restrictions for Hep C treatment again today based on sobriety and staging to remove barriers and increase uptake of Hep C treatment. We also heard about special populations that may not be traditionally considered, including rural groups and justice-involved populations that may be disproportionately affected. For those of us that are looking for guidance to come, there will be a fact sheet for members of IDSA, a policy brief and recommendations, and a letter to the NIH on key research questions. Moving to Dr. Elizabeth Hautzmuller from the Patient-Centered Outcomes Research Institute, she provided an overview of PCORI and PCORI-funded studies on the opiate epidemic, which span the care continuum from prevention of unsafe prescribing to treating the opiate disorder. She provided 2 examples for us, including work being done by Dr. Litwin at Montefiore, looking at patient-centered models of Hep C care for people who inject drugs, and an example by Dr. Talal at State University of New York, looking at patient-centered hepatitis C care via telemedicine for individuals on opiate substitution therapy. Next, we heard from Dr. Anika Alvanzo, who's here with us as well, on behalf of the American Society of Addiction Medicine. She provided an overview of ASAM and gave us some focus areas, including increasing access to addiction treatment through insurance coverage, growing the workforce, and removing administrative barriers, which have all been themes throughout the course of the day. She shared with us that the ACA and Medicaid expansion have created opportunities for more coverage of addiction treatments. Although the FDA has approved medications for substance use disorder treatments, we still have barriers like prior authorization, fail first policy, and barriers to limit access to treatment for opiate use disorders. ASAM is supporting local communities to ensure parity and access to opiate use disorder treatment, which is increasing parity is one of their priorities. And they aim to be a leader in expanding the workforce to include physician extenders, as we've mentioned, including nurse practitioners, physician's assistants, in both addiction medicine through non-board certified and board certified pathways. And she shared a need to increase funding, including NIDA and AAA, specifically related to the association between pain and addiction. Just a few more themes that came out in the final discussion. There was a discussion around the benefits and risk of making addiction training mandatory for ID physicians versus elective, and there was also interest in increasing that training amongst other providers, both physicians and physician extenders. There's an overwhelming desire to grow the workforce. Expanding Medicare coverage was another theme that came up as a way to increase coverage for opiate use disorders in our aging demographic who do have opiate use disorder. And then finally, thinking outside the box to reach rural areas. Dr. Springer mentioned using community health workers to deliver testing and treatment for opiate use disorders in more rural and underserved areas.